please move forward so that we have room in the back for those who come late. These forums are presented as a community service on important topics so that we can understand the issues that we face in life and perhaps act on them to improve our own life and the life of our community. My name is Jim Boyle, and I'm a member of the Forum Committee. Our forum today is entitled Your Brain and Changes in the Alzheimer Landscape. Nothing is more important to us than our brain because it really embodies who we are. My own mother had Alzheimer's for the last few years of her life, and every time I find myself forgetting things, I think that, oh, is it starting for me? And I'm sure many of us have similar thoughts about ourselves, our family, and our friends. And we want to understand as much as possible about the nature of Alzheimer's and whether there's anything we can do to prevent it and whether there's anything we can do to alter the course of it. We're delighted to have with us this morning Dr. Alan Lerner. Dr. Alan Lerner did his medical school training at Cornell University and his neurology training at Case Western Reserve University. He is currently a professor of neurology and director of the Division of Brain Health and Memory Disorders at Case Western Reserve Medical Center. So we're delighted to have him here. Alan?
Okay. Okay. Thank you, Jim. Can you hear me in the back? Good. Okay, so I'm going to keep it informal. I'm told that there's a lot of time for questions, but hopefully I'll answer some of the questions. So I was thinking on the way over here, in my tradition, the Jewish tradition, we spend a lot of time with the texts. And so we've been reading about the story of Joseph. So I just wanted to start with a little bit of thinking about this, because I think it encapsulates some very important issues that are still relevant. So, okay, so first of all, we read, it's always interesting, we read this story at this time of the year, and of course it's about a dysfunctional family and then a family reunion. So, raise your hand if family, don't have a dysfunctional family. Okay, I don't see anybody. Okay. No, so there's a couple things about Joseph that are really kind of interesting, and they actually do speak to some of the issues around Alzheimer's disease. The first is that he's recorded as taking care of his father. Okay, so he's the first person who, at least, late Bronze Age, who is recorded as actually taking care of a family member. He supported him. He goes to see him. It's interesting that when he comes to Jacob, Jacob doesn't recognize his children. That sound familiar? Something to do with memory. Though it's a little unclear because he also said to be possibly blind. And so he does deserve a lot of credit for that. Now, there's actually another interesting thing, which is the whole business of life experience. How does life experience play into aging and memory loss? So, before I get going on Alzheimer's disease, so the commentators say, why did Joseph died before his brothers? Okay, his death is recorded, and he died before his brothers. And some of the commentators said that why did he die? Because he sought power. Okay, right? He became incredible. So they already begin this folk notion that somehow our life experiences influence our life course. That this man who he was thrown in a pit and thrown in a jail, and has this incredible life story. Everybody knows Andrew Lloyd Webber. And all that, so they already sort of got the idea that possibly what you do in life and how you use your brain affects your life course. So that's all I'm going to say. It's really a fascinating story. Like I say, it's a story about family, and we're about to have a big family reunion here at Christmas, right? Everybody having some relatives come in. Okay, so just remember what he says to his brothers when they meet. He says, "Oh, don't worry, it was all part of the plan." He lets them totally off the hook. He like falls into this moral black hole. Yeah, sure, right. You threw me in, you sold me, you hoped I died, and but it's all okay. It's water under the bridge. Okay, so we're here to talk about Alzheimer's disease and brain health. And you know, brain health is a new term, and it's really a wellness model. Rather than just focusing on disease, you know, doctors like myself, we tend to focus on, we see sick people, and so we tend to focus on disease. And we're sort of trying to develop a new model, which we call brain health, which is a wellness model, and I'll talk a little bit about that in a little bit here. So a couple of questions that I'm going to try and answer, and Jim has already touched on the first one. So why is Alzheimer's disease or dementia such a bad disease? Why is it so bad? I mean, it's become one of the most dreaded things out there. So, you know, why is that? Second question that I get asked commonly is, where did all these people with Alzheimer's disease come from? You know, we never heard of this when we were all growing up. Who heard of Alzheimer's disease? You know, it was something for the textbooks. So where did all this come from, and what are the implications of that? And then what I would call the new science of Alzheimer's disease, which has to do with early diagnosis and early treatment, and how we're trying to really move to a wellness model, and I'll talk about brain health. Okay, so why is Alzheimer's disease so dreaded and so bad? So I really think that Jim hit the major point of this, which is that memory is bound up with identity, okay? And that this really strikes at the very core of who we are, or who we are as people, is, I mean, to some extent, you could say you are who you remember who you are. And that when you lose your memory, you, to a certain extent, lose your identity. And so it's really, really important to try to maintain that to whatever degree. Now, we recognize that memory is never a story about perfection, and we all alter it through the lens of our life's experience. So it's not a question of, memory is not a question of truth. It's not a journalistic kind of experience. It's, you know, we just kind of do the best we can. So, you know, I just wanted to point that out so that, you know, why has this become such a big thing? You know, it's also a huge societal issue. You know, Alzheimer's disease and dementia is an enormous public health problem. So we shouldn't just think of it, I mean, we think of it as it's about people, but it's also about society. So it's the current, and this is not meant to scare people, it's the truth, I didn't make this up. Currently, about 1% of global GDP is spent on care of people with memory problems. So that's about $1 trillion or something like that. It's bigger than Google or Apple. $250 billion in the United States spent on this. It's by 2050, it's estimated that 15 million people in the United States will be diagnosed with Alzheimer's disease. I like to, it's not a joke, I say it's like the global warming of neurology. I mean, it's something, it's this, you know, global warming, it's this thing that everybody predicts it's going to happen, it's been in the news, it seems inexorable, but, you know, it's also a call to action. What can I do on an individual basis that may play some very small role in changing that course? In other words, you know, what can I do to help the problem, address some of the issues, something of that sort. So, so this comes to the question of where did all these patients come from? So a lot of this happened really in the late 1970s and early 1980s when Bob Katzman and Robert Terry, who are neuroscientists in San Diego, they sort of take a look at the people who were living in nursing homes at that time. And they sort of said, well, this isn't really hardening of the arteries, It was just that they said that most of these people had Alzheimer's disease, and therefore they sort of, moved the goalpost and suddenly created this pool of about 2 million people. And then the projections have gone from there because we know that the population is aging, and so that, the drip, drip, drip thing, it was 2 million, then 3 million, then 5 million, and then 6 million, and, on and on and on. So that's where this group of people came from. Why did I not hear about it? Because it wasn't recognized as such. Alzheimer himself described a single patient in 1905 in Germany. She was actually 51 years old, so really pretty far outside of the normal what you think about Alzheimer's disease. And it really remained a medical curiosity for the better part of the 20th century until it was sort of recognized that this is really a common thing, and therefore that's where all these patients came from. We have had, I think that there's a lot of ambivalence about aging, and I think that this has affected how we think about it. I think that there's a lot of like, well, they're old, we don't want to, bother them, they've had a good life, this and that, it depends on how you think about this. We all think that cancer is a bad disease, right? So, and in cancer, which is really what become one of the models for how we're going to deal with this, we have drugs, they make your hair fall out, they make you sick as a dog, they, your blood counts drop, it's really, cancer chemotherapy is really bad because we perceive that cancer is a bad disease. I think I've tried to make the case that Alzheimer's disease is also a bad disease, but so how we think about it and the response to it may need to be proportional to that. Like I say, we have this sort of, there's been a lot of hands-off kind of thing. We don't want to do this. In fact, one of the things we're doing is a study of cataracts with people with memory loss and the role of the removal of cataracts. And there, it's clear that cataracts removal is part of, regular medical care. It's pretty clear to me that if you can't hear it or if you can't see it, it's pretty hard to remember it. That memory is really dependent upon perception. I think we tend to think of memory as this sort of motor function, like I remember, like I'm doing something. But I think that memory has a sensory part, like, I perceive it and therefore I remember it. And that memory has, like I say, a sensory part. But there's a lot of, again, ambivalence. People in nursing homes, well, we don't want to, we don't want to expose them to the risk of anesthesia. I'm not minimizing that. I'm just saying that I had cataract surgery. I can tell you from first person singular that it changed my life. It allowed me to read. I could drive. I could see where I'm going. I was the kind of kid who always wore the thick glasses since first grade. Now I have my little reading glasses in case I need to read up close. But, so cataract surgery, I can say this personally, like I say, it really changed my life. And I've heard anecdotally that, grandma was in the nursing home and they took out her cataracts and she, blossomed like a rose. And that's certainly not going to be true for everybody. But the point is that, now we have to go back and do, the sort of National Institutes of Health wants us to do this, controlled study and sort of prove to ourselves over and over again what we sort of knew intuitively. So, this is a big issue. So one of the issues we faced in Alzheimer's disease, and where we're going with this is, people have heard this, that you can't diagnose Alzheimer's disease until you die. And, you know, that's not real good. You know, if you want to intervene early, you want to be able to do this. On the other hand, we know that doctors can diagnose it with about 85% accuracy. And there's two proteins that primarily that deposit in the brain in Alzheimer's disease. The first is called amyloid protein. Amyloid protein is produced by splicing a normal protein in the brain, and that deposits around nerve cells and seems to injure them or possibly kill them. And the other is a protein we call the tau protein. Tau is also produced and is involved in sort of maintaining cellular integrity. So one of the great things, and there's been an enormous amount of work on early diagnosis. Part of this has been done by the so-called Alzheimer's Disease Neuroimaging Initiative, ADNI, actually started by Neil Buchholz, who was a Cleveland native, and has been going on for about 10 years. And so what we've learned is something really important, which is that the changes in the brain that in Alzheimer's disease precede any clinical symptoms by about 20 years. Okay, so an analogy. Who here has ever heard of the term, like somebody has pre-diabetes? You've heard this? Okay, so if you have pre-diabetes and then at some point you change to diabetes, so what is pre-diabetes? It's diabetes. Okay, and so like many conditions, kidney failure, high blood pressure, diabetes, there's this long process in the brain, in the body, that precede any clinical symptoms. So the idea is that the memory loss of Alzheimer's disease is actually one of the last things to happen, not the first thing to happen. And so this, you know, it's sort of like trying to understand kidney failure by looking at people on dialysis, or how the kidney works by looking at people on dialysis. You wouldn't, you know, that's kind of a little bit backwards, right? So one of the things that we've done, and this has because we're now able to image the amyloid through what's called a PET scan, or positron emission tomography, and we are able to see whether that amyloid protein is accumulating. This is important for two things, probably more than two. One is it creates a window of opportunity. So if we're going to intervene early, we now are able to move that clock back on when we're going to intervene from the time of memory loss to and now we are actually beginning clinical studies to try and prevent Alzheimer's disease. So there's a number of these studies. They're extremely large, they're extremely expensive, but they're really important because we've never had preventative studies. Again, I'm going to talk about lifestyle in a minute here, because this is, you know, this is sponsored by pharma, and so it tends to be drug studies. So we've been able to do that. The other thing that's come out is that probably about 20 to 30% of people who were enrolled in previous drug studies didn't seem to have very high levels of amyloid in their brain. And the question is, so were we enrolling in our research studies the right people? You know, if you start by saying, oh, well, I'm going to try, you know, I'm going to have this drug for diabetes, and a third of the people didn't have diabetes, you might not be surprised if your drug failed, right? And so it's really important that we study the thing that think we're studying. So the technology here is beginning to allow us to A, diagnose early, B, design appropriate studies, and then intervene to see whether preventing or removing this amyloid protein from the brain can be of help. But I also talked about brain health and the wellness model. So rather than focus on things like neurodegeneration, we're trying to focus on wellness. And to me, that is something that is across the lifespan. This does not, as I said, the last thing that happens is memory. So what are the things that affect brain function across the lifespan? Okay, lead paint abatement in children. Reading to children. We know that reading, the brain is the organ of learning. Are we reading and keeping our brains active? There's been an enormous amount of interest in concussions and football and the NFL. Anybody going to watch a game today? Yeah, well, we all love the highlight reel, right? I mean, we all love the guy who goes up for the pass and gets, knocked by the linebacker, right? Even before he catches the ball. We love that, but now we're discovering that almost 95% of professional football players have changes in their brain. Again, this tau protein, and the movie is coming out, Concussion, with, I guess, Will Smith. And about the NFL's got a serious product liability problem. It's probably as bad as the tobacco companies, but more to the point, it's, we're seeing changes in our in society. In Pee Wee football, they're not allowing tackling in practice, and some of the other high school and college football, they're not allowing heavy tackling because this is something that is known to be bad for you. So the developing brain is at particular risk. And then there's other things that have to do with this. Treatment of diabetes. I've come back to diabetes several times now, but diabetes is known to be a major risk factor for memory loss. And so it increases the risk of memory loss probably 20%, 30%. It's significant. Ditto with high blood pressure. Now, many of you have heard about the SPRINT study, which has been done here in Cleveland, and Jackson Wright at University Hospitals led the study, and it was published a couple of weeks ago, and looking at the effects of lower blood pressure goals, so on health. And the mind piece of this, the brain health, cognitive piece, has not yet actually been finished, and we've been working on that since about 2009. And so, whether lowering blood pressure or to like 120 over 80 versus about 140 over 90, whether that will actually produce better outcomes in terms of cognition. So this is really important stuff, because it's not help. Again, if you think back to what we talked about, the cataracts, help doesn't always come in the form of a pill. Okay, we're a pill-based society. If you go to the doctor and you didn't get a pill, there's this perception that nothing happened. That we have to be able to take this into account for ourselves. The effects of diet. When we talk about what else we can do to prevent memory loss, the three things that always come up. One is diet, the second is physical activity, and the third is social engagement. Well, okay, so we're all socially engaged. We're here today. That's good. The brain thrives on novelty and learning. So, and again, this is a folk notion, this idea of use it or lose it. This has been around for quite a long time. So diet, people have particularly focused on the Mediterranean diet, the one that is associated with high levels of fresh fruits and vegetables, not high in saturated fats, etc., things like that. Physical exercise. Another way to sort of encapsulate the knowledge here is to think that what's good for the heart is good for the brain. And So remember, there was that whole business we started with back in the, if we rewind the clock, this idea of hardening of the arteries. And lo and behold, cholesterol is important for the brain, and high levels of cholesterol may also lead to contribute to memory loss. So what's good for the heart? Diet, exercise, etc. So keeping healthy is really important. How can we prevent this? And I get a lot of questions from people. Well, my mother had Alzheimer's disease. What can I do? And we don't have strict preventatives. Now, I'm going to tell you something that's interesting. I went to this meeting a few weeks ago called Clinical Trials in Alzheimer's Disease, and the two takeaways, one was if you haven't heard about this great cure, it's because it doesn't exist, okay? You haven't missed anything. People think, oh, this new drug, this, that. I mean, there's a lot of teeth gnashing in this area. And the other one was that one of the keynote speakers gave a talk called "Have We Failed?" And that should sum it up. The answer he gave was no, but there's been almost more than 10 years here in the United States since the last drug was approved by the Food and Drug Administration for Alzheimer's disease. So there's been an enormous amount of work, but we are still sort of dealing with symptomatic treatments. We're behind the 8 ball. We are trying to get ahead of ourselves, and like I say, a lot of it has to do with early diagnosis, which will hopefully lead to early treatment. Is this, do we have some confidence that this will work? Well, it works in other conditions. If this was cancer, okay, Jim's here, right? Colon cancer, you wouldn't wait for that little polyp to be, the size of an orange, right? You'd run the other way. If the doctor said, well, we're going to wait till this lemon-sized cancer is the grapefruit-sized cancer, you'd say, forget it, I'm going somewhere else, right? Heart disease, we don't wait till you're gurgling or can't walk up a flight of stairs before we start treatment. Infectious disease, the same thing. We don't wait till your blood pressure drops to nothing. We treat urinary tract infections at the very first sign of some problems. So, early intervention has a long history. Now, there is a kind of a counter view, and my good friend, colleague Peter Whitehouse wrote that book called The Myth of Alzheimer's Disease, which I'm not going to talk about at great length, but is it part of normal aging? And this is a big question. So we've have we medicalized it? My hair didn't used to be gray. As you get older, you can't jump as high, you can't run as fast. It would be very, very, we know that every organ in the body participates in the aging process. Skin, heart, lungs, kidneys, bones, you name it. Every system in the body participates in the aging process. And so the question is memory loss inevitable? And the short answer, I think, is no. We know that there's all of these environmental factors, and we also know that there's genetic factors, and there's been a lot of interest in this, including some of the cholesterol-carrying genes that are associated particularly with the later onset. There's no one answer, and it's probable that our treatment responses will probably be somewhat similar to heart disease, where there's a kind of a cocktail approach ultimately. So it's not going to just be a pill. It may be health. What am I doing for health? Things that support continued brain function, So we may end up ultimately with kind of what I would call a cocktail approach to treatment. Those are the major issues. I think there's going to be a lot of questions, so I think I might as well just go with the questions, because I think that way we'll learn. Thank you.
Sorry. So we have a clipboard that's going to be passed around, and if we don't already have your email and you would like to be on our list for being informed about future forums, please add your email. And we also record these forums on YouTube, and if you're on our list, we'll also send you the YouTube link for the forum. Thank you.
Okay. So I'm here to answer the questions, because this is what's on your guys' minds, and I'll do the best I can. Yep.
You mentioned about when you had your cataract. When you had your cataract surgery, concern about when you were had anesthesia. And I was wondering, could you speak a little more about that? Because it seems to me in my family, I saw 2 older people have surgery, and shortly after that, they seemed to have memory loss.
Mm-hmm. Well, of course, I said nobody would ever touch my eye with a needle or anything like that, but that went out the door. This is an important question. So anesthetics, by definition, work on the brain, and they tend to be very fat soluble, and the brain is a lot of the fat and cell membranes, which are made out of fat, are in the brain. So there's no doubt that it affects, and a good friend of mine who's an anesthesiologist tells me it can stay in your body for up to 8 weeks. So I think, of course, it depends on the agent. There's very little evidence to suggest that the anesthetics themselves actually cause the problems. I mean, they make people worse for a period of time, but they don't actually cause dementia. I think that there's very little evidence that we know of to say that the anesthetics themselves are actually, sort of setting this process off. But certainly people can be more confused. I think it depends on doesn't so much depend on the route of anesthesia. In other words, spinal anesthesia is not necessarily better than general, though local would seem to be better than general anesthesia. The other issue that comes up is, I don't know why they had the surgery, but could other aspects, inflammation in the body, activation of all the inflammatory pathways, what role does that play? There's also an issue with whether or not when you have something like a surgery or an event that mark, a fall or something like that, I think that things happen and people start looking. And so I think that, it is that there's a number of issues that come up in that regard. Did I answer your question? Okay, good. Next? Yeah.
Can you talk a little bit about Lewy body dementia and how that fits into this picture?
Okay.
Lewy body dementia.
Okay, so when we talk about dementia, so some definitions are in order here. Dementia is memory loss. It's really a symptom. Dementia is like cough or fever or pain. It's a symptom, and therefore, as all of those symptoms may have many different causes. So I've sort of mentioned in passing some of the other causes of memory loss, such as head injury, stroke, brain tumors, vitamin deficiencies, a number of, a large number of things can affect the brain. There's a condition called Lewy body disease. The Lewy body is something you see under the microscope and is the hallmark of Parkinson's disease. There's a condition called dementia with Lewy bodies, which is has some features of Parkinson's, but probably about 50% of those people also have changes of Alzheimer's disease. The feeling is that Lewy body disease is underdiagnosed, that there's been a lot less research into it. Couple things I'd say about it. Well, first of all, the practical thing. So there's now a new Lewy body disease support group meeting at the Cleveland Clinic. My good friend Jim Leverins, who's come from University of Washington, is helping facilitate that. There's going to be a big international conference next month in Florida about Lewy body disease. So you'll probably be hearing some more about it. But it has features of Parkinson's and Alzheimer's, and it has a lot of behavioral disturbances, hallucinations, usually visual, slowed gait, falls, sleep disturbance, other psychiatric disturbances. And one of the things that we've also learned about Lewy body disease, similar to Alzheimer's, is that some of the symptoms of it, particularly some of the sleep symptoms, like talking in one's sleep, acting out one's dreams, may actually precede and may be the first symptom before memory loss, again, going back 10, 15, 20 years. So it's an important thing to recognize. It's treated similarly to Alzheimer's, but it is considered. Now I'm going to just take this one more step. Does it matter? Does it matter what you call it? And so the answer is both yes and no. Okay, so I think that this is really about people. And when you're talking about people, the person's a lot more important than and care. We started this whole discussion with talking about care. It doesn't really matter. You have to care for, you love somebody to have and to hold in sickness and in health, right? But on the other hand, from a really practical, if you don't know what you call, first of all, if you don't have a name for it, that's extremely anxiety provoking to the whole family. What is it? This unknown, this great unknown is extremely anxiety provoking. So it's important to have a name. Now, you don't mind if I go back to the Bible here. You look in Genesis 2, the first thing Adam does is name the animals. And so naming, this is really important from a psychological standpoint. We need to know what we're dealing with. Okay? When your car is making some funny noise, you go to the mechanic and he says, oh, that's your radiator or whatever. That's your alternator. And lastly, the most progress in medicine has been made by splitting things apart from other things. And that is just kind of the way we do it. Analysis means to break apart. And so, if we don't sort of separate things and learn how they're different and how they're similar and how they're different, it's unlikely that we're going to make huge amounts of progress by just saying, well, just kind of lumping everybody. Again, this comes to a certain amount of ambivalence, I think, about ambivalence about aging in general. Yeah. Next, Jim. Yeah, go ahead. Okay.
Any evidence on I'm sorry. Is this better? Any evidence a plant-based diet helps in prevention? Any evidence that doing crossword puzzles helps? And how about seniors that take senior courses, that take educational courses versus the control group? Any data on that? And how about the diagnosis age-related memory loss? Is that a valid diagnosis?
Okay. Well, I'm not going to answer them in the order that they were asked. So the first one has to do with crossword puzzles. And so, one of the big issues in this area about brain games is to what extent it carries over. In other words, I think what the feeling is that, and this is about prevention, and again, there's no known preventatives. So one of the things about crossword puzzles is it probably doesn't generalize. In other words, doing crossword puzzles doesn't help you find your car. Okay? But what's also pretty clear, and this has been, some people who've thought about this a lot in the field have suggested that people aren't going to wait around for the double-blind, placebo-controlled study about brain games. That we're not going to wait for this. The people are going to do it. 50 million people are using Lumosity, and so there is some evidence about brain games that they do actually help, and ditto learning. I think learning about new things. It's not clear that one thing is better than the other. Is watching television. Does it matter whether you watch Monday Night Football or Masterpiece Theater? That's a little too granular, so to speak. So I think that keeping the brain active, and ultimately, really, what does it come down to? It comes down to quality of life. And, I think that really it has to do with people taking some, saying, what is it that I want? What's important to me? What are my values? And how do I get there? That to me is extremely important. Diet studies have been disappointing for the most part. Nuts seem to help. Red wine, it's full of antioxidants. It seems mostly that these are sponsored by the French. We don't know that, diet studies, I don't know that, a vegetarian diet per se, though, diet seems obviously to be linked with activity. This whole business about fish oil, this comes from studies of the Inuit. But, they do things that we don't do, right? I mean, they drag a seal across the ice for, live like an Inuit, eat like an Inuit. And it's not clear that eating, if you're sitting in suburban Shaker Heights, how much fish oil is going to help you. We did do a study of DHA. It was a 0. We did do a study so some of this has been looked at. Some of the supplements have been looked at, not all of them. Vitamin E in particular seems to do something to prevent memory loss in people with established memory loss. The last question you asked is actually a very interesting one, which is to recognize about age-associated memory impairment. And the most important thing to recognize here is that normal is a moving target. And, as I sort of implied, so what's normal at 80 may not be normal at 50. Okay? So that's, and so I think it's really important not to again, look at the person. This is for me, to look at the person and not at the numbers. What is this person doing? How is this affecting their life? Who hasn't made a wrong turn? Who hasn't been late for an appointment? Who hasn't, missed something or not paid a bill on time? Everybody in this room, right? And so we can't expect perfection from ourselves. We know that changes as we get older. In general, the biggest changes occur in speeded functions. You can't do things as quickly. But on the other hand, we substitute something called experience and wisdom. I know what I'm doing. Just trust me. I know what I'm doing. I know how to make these cookies or whatever. I don't need the recipe. And so, I think there's a balance. There is this concept called Now, this is also important because I'm sorry, you ask a really important question, which is this whole business of first of all, what is normal? And then this whole business of what people would nicely call subjective cognitive impairment. So normal has two meanings in this context. One is all my friends, have the same problem. So, this idea about a normal distribution. What's normal for a 70-year-old or 80-year-old. But the other important thing about normal is what's normal for you. And that's really the key question. So if you look at what's been learned about what people would call subjective cognitive impairment, not the worried well, not patting people on the back and saying we're all getting older, it turns out that it's actually fairly important. And so we really, at least in the clinical experience, have to take subjective cognitive, the idea that my memory isn't as good as it used to be is very important, because those people are really, they know themselves well, and I think we really have to respect that. And the numbers are a little scary. In other words, probably about 50% of those people will eventually have really significant memory problems. So if we're going to intervene early, those are actually the people we want to be studying or, accumulating in research cohorts, et cetera. There's actually some interesting things, and some of it's a little creepy, but I'll go into this anyway. So there are some people I know who are interested in those like online brain games. And like when you would sign on, they would say, like, there's a checkbox. Can we look at your scores? And if we think there's a problem, can we like contact you? So there are people who are beginning to do this, with behind the scenes, like sort of like look at how people are doing longitudinally on things like lumosity. And, then in the future, they may be sending out like, have we got a study for you? Like I say, I find it a little creepy, as kind of an invasion of my privacy, except I guess if you check the box, you've agreed to it. But there are definitely people who are beginning to think like that. Yeah.
So I'm interested in this.
Next, we'll go back there. What? Right here. Okay. Jim will get
I have
you
a
next.
question about depression.
Uh-huh.
Depression in older adults and how it can sort of dovetail with some of the symptoms of memory loss or what might be aging. And can you speak to, I don't know, the success of possibly recognizing and treating depression in older adults?
Okay. The question is about depression and its relationship to memory loss. So depression is common and has some similarities to Alzheimer's disease in terms of alterations in so-called neurotransmitters, chemicals that are involved in cell-to-cell communication in the brain. In the case of depression, some things like serotonin. In case of Alzheimer's disease, a chemical called acetylcholine. Mood and depression are, first of all, changes in that are common as people get older. Depression can mimic. There can be memory loss associated with that. I see a fair number of younger people with bipolar disorder, so-called, where they have manic depressive illness, who complain of memory loss, and this has actually been looked at This has been looked at, and they do seem to have trouble with what we would call executive function, planning, judgment, abstractions. The medicines play a role, that many things that are used to calm people down can themselves be associated with memory loss. We know that some 1/3 of people with Alzheimer's disease, which is the paradigm for dementia, have depression. This can also be present in Lewy body disease. There's another interesting thing, and I'm going to talk about this, which is the issue of apathy. And apathy is not depression. Apathy is one of the more, just the sense of like, I can't sort of be happy, I can't be, it's a motivational thing. And actually we're we're part of a large nationwide study on apathy in dementia, using Ritalin of all things. It's from the National Institutes of Health, so it's starting here. I'll be happy to give you details after that. The so-called ADMET-2 study. So there are people, depression is hard, there's a lot of questions about, where exactly one ends and the other starts, but apathy, which is not depression, is actually becoming a target. And I would say in some ways behavior is actually maybe a better target in dementia than memory. Behavior may actually be an easier target. At least that's the way I seem to see the field going. Jim.
So the issue of the wellness model and the fact that the changes in the brain are occurring 20 years before, and the idea that maybe you can see amyloid with a PET scan, is interesting to me, but also kind of scary. I mean, as I mentioned, my mother had Alzheimer's,
right.
And I worry about this. And you talked about the analogy to cancer, and if you had a pre-cancer, you'd want to get in there and do stuff right away.
Right.
I mean, this scares the hell out of me. I mean,
it's very scary. I think we should be concerned a lot. There's obviously issues of cost. And it's not just PET scans, spinal taps and spinal fluid can show changes as well. There's issues of cost, invasiveness. What are you going to do about it? I mean, the big question has always been, so now what, doc? And that's where, there are starting to be the so-called A4 trial, which we're participating in, which is an international study. The anti-amyloid treatment of asymptomatic Alzheimer's disease. I guess that's 4 A's. But people are rising to the challenge, but it is far from a settled case that any of the planned interventions really, what is their utility? So this is a big question. I think it's going to take many years to answer. We'll probably be talking about, that study, which was started now, is probably not going to have any results till 2019 or 2020 possibly. So I think we have a long ways to go. And who should be in them? There are a number of other prevention trials. One of the things I worry about is how expensive these studies are. You're talking about $100, $150 million per pop of a study, and are we studying the right thing? Or would we be better to distribute books to children? Where's the payback? I think that these are not insignificant questions. Yeah. Bob has a question.
We've been talking about memory loss, but my question is, do we have any information about whether it's loss of memory or loss of access?
That's a very interesting question. Yeah, we've had this sort of mechanistic model of, encoding, storage, and retrieval, sort of like magnetic tape. Sometimes it is in there. Sometimes, probably both of those are, so the question is it, do I know the answer but I just can't tell you? Or, so, it's interesting, first of all, why don't you know somebody's name? One of the most common reasons is you never knew it in the first place. You can't lose what you didn't have. I don't know that I think probably both are operative here, that there's access issues as well as, speed matters, I'll think of the question in 10 minutes, I think I mean, personally, I'm doing some studies that look at, speed of retrieval. And I think speed actually does matter. That's a fascinating question to which I'm not sure we have the answer.
I have a situation that if I forget a name or forget a word or use the wrong word, my husband thinks that I should go and be tested. So, so I've been tested 3 or 4 times, and I can count from 100 down by 7s, and I can draw the clock, etc. So I'm asking you, do you think that it's a good idea that everyone at a certain age perhaps goes and be tested to see if they can remember that 3 words, etc.?
So this is interesting because the Affordable Care Act does sort of encourage that. And, should mental status testing be like a colonoscopy? The answer is probably no. The case finding rate, unfortunately, the case finding rate is very low. Again, if you have a question about your memory, it's how do we efficiently screen for this? And I think that kind of approach is actually not very efficient. So health fairs, that sort of thing are really not a very efficient way. And the Preventive Task Force, the U.S. Preventive Health Prevention Task Force sort of agrees, even though it is sort of built into the Affordable Care Act now that they will pay primary care physicians to do mental status screening. Yeah. Question? Yeah. Yeah.
Also the problem that there's really nothing to do if you found out that you were having memory problems early on. I mean, I've been listening to these kind of talks for about 10 years now, and I really haven't heard anything that early diagnosis would really serve a person very well to know. I mean, there's not a pill, there's not a lifestyle.
Yeah, well, there's the other, we talked about lifestyle, but there's the other issue is of life planning. So, again, what has been the experience here? So there was a study, it was actually, some of this was done in Cleveland. Cleveland's a great place for a lot of these studies have been done in Cleveland, and we should be very, very proud of what has been accomplished locally, or, participation in these large consortia, where they gave people their genetic information about their Alzheimer's risk. So the only thing that they did differently is they bought more long-term care life insurance. Okay, so, I mean, that's a very limited sort of thing, but, you don't wait to retire till retirement to plan for retirement. And I think this gets back to the question that got asked before, which is, what is it that you're trying to accomplish? And, you're trying to accomplish living your life in a moral sense, in a quality sense, to hug your, and I think ultimately we do come back to carpe diem, which is, you can't live your life that way. You can't just say, well, we don't know what's going to happen in 20 minutes, let alone 20 years. So, you bring up a really good point, which dovetails with the questions that were asked here from the front row. And, I think it becomes about personal choice, life planning. It's not totally about pills. And, should it be medicalized? And, we just got done with the screening question, and I kind of, dissed it a little bit that, that's not really a good approach. But it's important to recognize that if you have concerns, that there are ways that those can be assessed. And, with sophisticated testing, whether it's neuropsychological testing, paper and pencil type question, scans. I mean, to me, that's really that we are able to sort of at least begin to address that. And, what we'd love to do is get to the point of personalized risk assessment. What's my risk in, 5, 10, 20, 30 years? I think that's really important. We're not really there yet at that personalized risk assessment, which we do have for things like stroke and heart disease. So I think that that's something that, you know, a direction where we really should probably be putting some of our resources. Yeah.
Okay.
Oh, wait. Okay. Over there.
Should I go ahead?
Sure.
Okay.
Whoever got the
back here.
microphone. Yeah.
Two questions. One is early onset Alzheimer's substantively different than the later onset? And second question is, what about the role in music with dealing with Alzheimer's patients? I've seen some of that.
Okay. Early onset is proportionate, much rarer. One of the groups is that it suffers from early onset is people with Down syndrome, and which they have a extra copy of chromosome 21. The amyloid, the gene for the amyloid protein is actually on chromosome 21, suggesting that overproduction of that may lead to that. So it's, you know, there are other causes of memory loss, and some of those are more common in younger people. So not everything is Alzheimer's disease, and that's a big part of the message. Music, you know, music is soothing. Rhythm, you know, dancing is a good exercise. It's social. I don't know if there's a more specific part of that question you wanted to ask about music. Right. I think it bypasses, because of its emotional appeal, it bypasses a lot of the sort of just rigid categorical thinking. Okay, let's get somebody over there.
Doctor,
Uh-huh.
you've clarified for me dementia is a symptom,
Mm-hmm.
not an end product.
Right.
That clarifies many of the impressions that I've gotten by reading and listening.
Mm-hmm.
Dementia is a symptom, not an end. Am I mistaken?
No, you're correct. Absolutely. So I think that it requires a little bit of further investigation. You know, we know that probably 60% in older people after age 70, let's say, or 75, about 60% of that is Alzheimer's disease, but not, you know, that's not 100%. So, and some of that may be reversible, some of that may be treatable, some of that may be less treatable for, you know, for that matter. So I think it's really important to, you know, just take it to the next step. Yeah. Wait, we had here in the front row, or you've also been waiting, Bob. But let's.
I want to ask a question about types of memory and the relationship to Alzheimer's. Example. When I was young and taking piano lessons, third, fourth, fifth grade, I could memorize things extremely easily. It was just nothing. I just did it. And then I had a teacher later on, and I didn't question it. I had a teacher later on that said, well, what do you see on the page when you are playing by memory? Well, I never saw anything on the page. And suddenly I thought, my gosh, I'm doing it wrong because I don't see these notes on the page. And that's how that teacher saw his memory. Mine was physical memory in the fingers. His was intellectual memory in his head. What's the relationship there between types of memory and Alzheimer's?
That's a very good question. So memory can be broken down into different kinds of memory. So there's episodic memory. So that's like, what did I do? Things I've, you know, remember these 3 words kind of memory, okay? Things that have happened to you. So episodic memory is things that have happened. Then there's semantic memory, things you know. Whose picture's on the $5 bill? You know, you didn't see Abraham Lincoln, but you know that, you know, these are things you know. And then there's what people would call motor memory, which is exactly what you're talking about, which is how to play the you know, you never forget how to ride a bicycle. So Alzheimer's disease, because of probably anatomical reasons and where it affects in the brain, primarily, at least most of the time affects episodic memory. Wait, the microphone's been passed back there. I'm sorry.
Yeah, Alan, do we have any insights from worldwide studies from other parts of the world? And secondly, are there socio-economic differences in terms of the epidemiology of Alzheimer's?
Yeah, there are a lot of studies that have gone on in isolated populations throughout the world. China has a big problem. We talked about this, and I started by talking about the economics of this. And it turns out that half of the Alzheimer's patients in the world, half of the dementia patients in the world are in Asia. So we think of this as sort of a North American, European problem, but Asia, and especially with their one-child policy, where you don't have brothers and sisters nor cousins, is really going to change the social, social structure. So by 2050, again, some 650 million people in China over age 65, and they've got a serious issue there. Lifestyle has been looked at. There have been cross-cultural studies comparing African Americans in Indianapolis to people in Ibadan, Nigeria. So there have been a number of these to look at, Japanese Americans raised in Hawaii versus in Japan, in veterans. There have been a number of different cross-cultural studies. And, I think they have focused us again on diet and particularly early life experiences, seem to play a role. So I think that the adequacy of nutrition when you're growing up probably plays a role. Other environmental toxins play a role, and some of those certainly socioeconomic determinants of that sort of thing. The genetics obviously also vary by population. So the most common gene, the so-called ApoE gene, is more common in certain populations, particularly Caribbean and Hispanics, but less so in African Americans. So there's variance between populations that, but we always seem to be studying the same things. Okay. Let's go ahead.
I'm wondering, what are the symptoms of vascular dementia? Are they different from the other kinds, and how is it diagnosed? That's one question. Then if I'm allowed to, I have another one. I understand that some drugs can cause memory loss. And for example, and I understand also that sleep deprivation can cause memory loss. So if you don't sleep well, you have sleep disturbance, and you take Ambien, well, you're sort of damned if you do and damned if you don't. And what is your feeling about that?
Okay, so let's just start with the second question, because I think it's so first of all, it's true. Many medications can cause memory problems, and particularly things that are sedating. Sedatives seem to cause memory problems. Ambien has been associated with people who get up and walk around the house or drive and go get a hamburger and don't remember it the next day. And so that's and so sleep. The biggest cause, one of the biggest causes of sleep deprivation is sleep apnea, and sleep apnea results in actually waking up hundreds of times per night, so that you're tired the next day. And so this idea that if you can't pay attention, it's harder to remember. Well, I think it's primarily attentional. Attention. So it's also laying down new memories. It's not just remembering the things from far ago. It's are you paying attention to what's going on today. So I think that there's this difference between so-called long-term memory and short-term memory. I got asked about the different kinds there, but we're critically dependent on our short-term memory. Where did I put it? When's the appointment? What's happening today? Who called on the phone? I know I graduated high school. I'm not going to forget that. But that's not like going to help me get through my day. I had to be here at 9, Jim told me to be here at 9:15. I was here at 9:15, right? What else am I doing this afternoon? That we are really dependent on our short-term memories, not just our long-term memories. So attention, sleep deprivation, and also the medications tend to affect attention, and that's probably at least part of why they're doing that. The question about vascular dementia is the question is about stroke-related dementia, and so stroke is another cause of dementia, and it can sometimes be small strokes, so a lot of small ones equals one big one, and it tends to be the things that tend to change with that are walking, gait with vascular dementia, and the other one that people talk about is so-called executive function, again, planning, judgment, thinking type things, as opposed to, so it tends to be more thinking than memory, but obviously both they're sort of linked.
There's time for one more question.
Okay, got the hand up first.
You alluded to a study that's about to start in which you will be using Ritalin.
Right.
I'm very curious to hear more about that, particularly since my father, his sister, and their mother all died of Alzheimer's. I'm wondering if I'm a candidate for your study.
That's not a prevention study. We do have a number of different prevention studies. So Ritalin is the drug that's been used in ADHD, right? Methylphenidate. And so, like I say, the study is really looking at apathy, people who are apathetic. It's not a. We do have prevention studies. I'll be happy to give you my card afterwards, and I guess we're done.
We'd like to thank Dr. Lerner for a wonderful presentation.
Thank you.
I'd like to remind you that this is our last forum of the fall series, and we will restart with the winter-spring forum series on January 17th, and Armin Budish will be here. He's the Cuyahoga County executive, and he'll be talking about an update on important initiatives in the county. I'd also like to mention that everybody who wishes to is welcome to attend the service upstairs, which begins at 11 o'clock this morning. And Reverend Daniel Budd will be talking about, we didn't used to do it that way. I'm not sure what that implies, but so thank you again for coming, and thank you, Dr. Lerner.
Okay, thank you. I'll hang out for a little bit.
Can I ask you a few more questions?
Sure.
Shelley Polster, I'm a retired physician.
Okay.
And do you know the other Al Lerner, the radiologist? You met him?
I've met him.
Couple
Good
questions.
friend of yours?
Yeah.
Yeah.
Does yoga help at all? Yoga?
People are looking at it. I think the thing is you have to want to do it, and these things are really important. I mean, yeah.
Worth a try.